District Hospital also looked at 186 patients that came in with liver cirrhosis and its related complications. And the median age of those that presented at that time was 46 years. Okay. And hepatitis B was the main cause of liver cirrhosis. But here you can see that alcohol is closely to hepatitis B. And this also tells you the damage that excessive consumption of alcohol is causing to our liver. I always say that cirrhosis, the causes is the same everywhere, but varies from country to country, and even in the same country, from one district or one region to another region. Okay. So if you go to district hospital, if you will be able to reduce new infections if you will be able to prevent chronic hepatitis B from happening, then it means that we need to pay attention how we can eliminate hepatitis B, or how we can prevent it from occurring in newborn children. So to achieve this, then it means that hepatitis B vaccination, prevention of mother-to-child transmission, injection and blood safety, harm reduction, and then also identifying those who have this infection and putting them on treatment is key in achieving the 2030 elimination target. So Hep B is a global public health threat and the world's most common serious liver infection. In 2015, WHO estimated that about 257 million people are chronically infected with hepatitis B, and close to 900,000 people die from liver cirrhosis, liver failure, and then hepatocellular carcinoma. But the worst thing is that all those that have chronic hepatitis B, less than 10% know their status. Okay, so we put chronic hepatitis B as a silent killer because you have it, but you will not experience any symptoms. I always compare it with hypertension and diabetes. Okay, so if you want to know whether you have hepatitis B or C, and you are waiting for you to experience symptoms in your body before you seek attention, then that one will be too late. And then aside that, only few people are on treatment. In Ghana, the major mode of transmission is mother to child and early horizontal. Okay, some studies were done in this country to find out why early horizontal. And those who are a bit older and have stayed in villages before, you realize that, or what they found out was that, those times, I mean, you find it difficult to get chicken or meat, to chew or to eat. So sometimes your friend will be chewing meat, and then you go and ask your friend to give you some. And then the partially chew meat, your friend will bring it out and give you some. So if that child have a sore in the mouth, and you too, you have a sore, there may be a blood in there. And if the child have hepatitis B, then the one that he has given the meat to is also likely to have it. And then they also found out that, Mampele also. I mean, those who are can. Okay, there is this itchy rashes that most of the time children will get. And then there will be fluid inside. So if a child, you have it, you cannot scratch your back. So your friend will come and scratch it for you. You go and scratch your friend back. The fluid that comes out contains the virus. So you share among yourself. Okay. That's why the horizontal transmission normally occur among children. So if anybody have hepatitis B in the household, if a child is delivered and sent home, the probability of the child or the baby getting the hepatitis B is high. Because in our traditional setting, the things that we do to our babies when they are sent home. And then hepatitis B is very contagious. It's 100 times more infectious than HIV. Okay, because about a ml of blood that comes out from an infected person contains millions to trillions of the virus. So when you get in contact with it, then the transmission occurs. And it is also carcinogen, second only to tobacco. All right. So the hepatitis B itself causes cancer. It's a carcinogen. So That's why, as I said, about 80 to 90% of all those that develop cancer of the liver is from hepatitis B. So globally, Ghana, because our prevalence is more than 8%, we find ourselves in a highly endemic country. When it comes to transmission, I think there is a lot of misconception or myth that we spread about in terms of transmission of hepatitis B. And based on this myth is creating a lot of stigmatization in our community. So when people get to know that you have hepatitis B, they tend to stay away from you. But this slide tells us body fluid, that the virus is highly concentrated. So they are found in blood, serum, and then wound exudate. When it comes to urine, feces, sweat, tears, and breast milk, even if they are there, it's very low. So we always say that hepatitis B is not transmitted through urine, through sweat, through tears, and also breast milk. That's why breast milk or breastfeeding is not contraindicated to a mother who is positive to hepatitis B, even if the mother have not the baby have not received the immunoglobulin or the vaccine, because the virus is unlikely to pass through breastfeeding for the baby to get it. And moderately in semen, vaginal fluid, and saliva. But we all say that kissing does not or is not a mode of transmission, because if you have intact mucosa, and even if the virus is in the saliva, there is no way they can penetrate through intact mucosa. So sometimes people will ask, what about if there are sores or cracks in the mouth? Then that one is not normal. Okay, it's not normal kissing. Okay, because blood can come, and that one possibly infection may occur when such situation arise. And then the other ways that is transmitted, we all know. You know, health workers, we are highly at risk. So if you are here, a health worker practicing in a clinical area, and you have not received vaccination, I will be very surprised. Okay. And as you go along, you also notice that it's not everybody that have received the 3 doses of vaccine that will produce antibodies. About 10% of all those that have received 3 doses of a B vaccine does not produce even a single antibody. So those people are not protected. So if you are a health worker, you have received 3 doses, but you haven't checked your antibodies after vaccination, it's important to check it. Other than that, you can't go about saying that you have received vaccination, so you are okay. All right. So I've talked about perinatal early horizontal transmission, but the most important risk factor for perinatal transmission is the viral load and then the E antigen status. Okay, so if the E antigen is positive, if the baby doesn't receive any vaccination or immunoglobulin, about 90% of the babies will become infected. They will get the infection from their mothers. Okay. And also studies shows that if the viral load of the mother at the time of delivery is more than 200,000 international units per male, even if the baby receives both the vaccine and the immunoglobulin, about 10% of the babies will have what we call post-exposure prophylaxis failure. So the 10% will still go ahead to develop or to get the infection, even if they receive both the vaccine and then the immunoglobulin. That's why it's not enough just to know the surface antigen status of a pregnant woman. If he want to comprehensively prevent mother-to-child transmission, then it means that the E antigen status of a pregnant woman should be known, and then the viral load of the pregnant woman too should be known. Because when we know it, it gives us idea the kind of intervention we should give. And all babies that get infected during delivery, about 90% of them become chronically infected. But if you are adult 5 years and above, and you get the infection, only about even less than 5% will develop the chronicity. Okay, so it means that if you really want to reduce infection or transmission of hepatitis B, then we need to target the babies that are being delivered. And so for acute infection, as I said, the, the, the babies, about 90% of them will develop chronicity. But when it comes to adults, it's only about 5%. And all those that develop chronic infection, it's only about 40% of them that will either develop liver cirrhosis or cancer of the liver, leading to their death. Okay, close to about 60% of them will have inactive infection, and those patients may not require any treatment in their lifetime. Okay, so it's not everybody that tests positive to surface antigen that we put them on treatment. So you need to evaluate them to determine which people are likely to develop liver cirrhosis and cancer of the liver, so that you put them on treatment to prevent the cirrhosis and then also to prevent the cancer. But know that hepatitis B cannot be cured. So far, we don't have medication or treatment available that can eliminate the virus from the body. What we can do is to suppress the multiplication of the virus so that there will be no virus in the blood to attack the liver. So we tend to make sure that we treat patients to get to an undetectable level when they do their viral load. But you see, hepatitis B is dynamic. When you do the test today and the virus is undetectable or less than 2,000, if it is less than 2,000, we say that that person have inactive infection. Okay, you can have inactive infection today, the next day the infection can become active. Okay, so it's not one often. The patient have come, oh, you don't need treatment now, then you leave the patient. No, you need to follow up the patient at least every 6 months to make sure that they are still in the inactive state, because some of them may be inactive today. They will go to hospital, they will tell them, oh, you don't have issue, the virus is not multiplying, you don't need treatment. 5 years time, 10 years time, they will come and then they have liver cirrhosis or cancer of the liver. And the reason why we cannot eradicate hepatitis B or cure is because, hepatitis B is a double-stranded, but it's incomplete. When they get to the hepatocyte, they repair themselves, and then they attach themselves to the DNA of the hepatocyte, the liver cells. So for now, we don't have a medication that can eradicate the DNA of the hepatitis B that have attached themselves to the liver DNA. And then the DNA that have attached themselves to the liver DNA become the source of multiplication. Okay, so now the drug available that you use to manage them is to stop the virus from multiplying. So it's like a barrier, you put it there. Once you take the barrier off, the virus will start multiplying again. Okay. And For you to determine whether the patient may require treatment or not will depend on the viral load, the ALT level, and then severity of liver disease. Okay, the status of the E antigen is also important. The age of the patient, family history. Okay, so if you are taking a history from a patient with hepatitis B, we are more interested whether a family member have hepatitis B and have that person developed HCC or liver cirrhosis before. Because if that answer is yes, then it means that that person too is more likely to go through that same natural process. And those patients, we may put them on treatment earlier compared to other patients without family history. So the goal is to prevent cirrhosis, HCC, and death from viral hepatitis B. So we tend to improve the liver function test by normalizing the inflammation and then reduce the viral load, as I said, to an undetectable level. We improve liver histology, then try to make sure that at least those who are E antigen positive, they will seroconvert to E antigen negative, and then production of antibodies to protect them. And some few people are lucky. So sometimes they are able to lose the surface antigen. And when you lose the surface antigen, then we say that you have a functional cure. Okay. And that one, we can stop you from taking the medication. Other than that, the treatment tends to be lifelong. The drugs available or drugs that have been found to have activity against hepatitis B is tenofovir and entecavir, lamivudine, tarbivudine, adifovir, and pegylated interferon. Okay, but for now, you don't use lamivudine anymore because of low barrier to resistance. The first line drugs that we use is tenofovir, entecavir, and pegylated interferon. But I see we normally do not use pegylated interferon anymore because those that are put on pegylated interferon, less than 40% of them will respond. And you know, pegylated interferon is an injectable form. You will inject it every week for 1 year. Okay, so about 48 weeks, every week you have to get injection. It's also quite expensive. And imagine after going through 1 year of injection and you are told that, oh, you didn't respond. Okay, so, and it also comes with a lot of side effects. Okay, if you're a man or a woman, if you're a man, you are taking it. Whilst you are taking it, you can impregnate your wife. And even after 6 months of finishing the, the medication, you will still be on contraceptives because of the teratogenic effect of pegylated interferon. It causes suppression of the immune system, and because of that, it's not that friendly. So the first line for us here in Ghana is tenofovir, because tenofovir is potent and also have a high barrier to resistance. Okay, and then also we have generic forms available that make it a bit cheaper. Okay, for patients to afford. So tenofovir is the first line drug that we use in this country. And entecavir is quite expensive. I think it's about 900 Ghana for a month supply. Okay, and then tenofovir, averagely you will get the 130 up to about 150 Ghana cedis for a month supply. So we normally use tenofovir as our first line. So based on what I have said, then which people with hepatitis B will require treatment? And this is where sometimes there is a bit of confusion among health professionals. Okay. So we say that patients who test positive and are at high risk of developing cirrhosis of the liver or cancer of the liver, then you put them on treatment. And what are these patients? So for those who are E antigen positive, if the viral load is more than 20,000 IU per mil, and the ALT is 2 times upper limit of normal, then you put them on treatment. Because those patients, there is inflammation ongoing, and they are at high risk of developing cirrhosis of the liver or cancer of the liver. But if the viral load is less than 20,000, for those who are E antigen positive, less than 20,000, then we consider them to have inactive infection. And for those patients, we monitor them. Those who are in between, that one refer to a specialist to determine whether the person will require treatment or not. Because some of them may require treatment. Some of them, we have to monitor them. Okay, so that is a gray area. And I think that one is better you refer to gastroenterologists to determine whether the person should be put on treatment or not. But for those who are E antigen negative, the value is 2,000 and above instead of 20,000 in E antigen positive patients. The reason is that if you are E antigen negative, it means that you are not supposed to multiply. Okay, the virus is not supposed to replicate. But you know, viruses as they are. I mean, you know, COVID-19 is a Delta variant, Lambda variant, this variant, this variant. That's how viruses are. Okay, so some of them will mutate and they will be able to escape the protection of the E antibodies. Okay, so once they are mutant, it means that they are more dangerous than the normal ones, the typical virus. And for them, we tag them as 2,000. So if it is 2,000 and above, then it means that they are more dangerous and they can lead to cancer of the liver or liver cirrhosis. Okay, so these are patients that are more likely to develop cirrhosis of the liver. If you see a patient very high viral load, the ALT is normal, the abdominal scan is normal, the person doesn't have liver cirrhosis. Those patients, we don't rush to put them on treatment. We put them on monitoring. You monitor them because sometimes, you see, the body immune system itself can suppress the virus, and even sometimes it eradicates them from the body. So for those patients, we tend to monitor them. Then the other group of patients that require treatment is if hepatitis B is positive and the person have developed liver cirrhosis. That one, you don't need the viral load to determine that whether they require treatment or not. Once the person have developed liver cirrhosis as a result of hepatitis B, you put that person on treatment indefinitely. Okay, so, and then you see, for pregnant women, they follow the same indication of the non-pregnant patient or any other patient. And tenofovir has been found to be safe in pregnant women. So pregnant women too can take tenofovir. So if the pregnant woman have liver cirrhosis, you start treatment. If the ALT is high and the viral load is high, you put them on treatment. But as I said, if the viral load at the third trimester is more than 200,000 IU per mil, then it's likely that even if you give the immunization and then the vaccine, the babies are not going to respond. They will still go ahead to develop the hepatitis B infection. That's the post-exposure failure. So for those mothers, we tend to put them on treatment at the third trimester. So if you have a pregnant woman have tested positive, at least at the third trimester, try to know their viral load. And if you get to know their viral load, it will help you to determine whether you have to put them on treatment at that time or not. It will reduce the viral load at the time of delivery so that it reduces the post-exposure failure that I have talked about. So for pregnant women with high viral load at the third trimester, even if they don't qualify for treatment, you put them on treatment at that time to reduce the viral load. And any patient with positive hepatitis B, if you are going to put them on immunosuppressive therapy, chemotherapy, high dose steroids, biologics, adalimumab, rituximab, and all those biologics, that will reduce the immunosuppression. Even if the viral load is undetectable, once the surface antigen is positive, we put them on treatment, because once the immune system comes down, most of the patients will reactivate. Okay, the virus will start multiplying and they tend to attack the liver, and some of them will die from liver failure because of reactivation rather than the cancer or the autoimmune condition that you are managing. So before you put anybody on immunosuppressant, you need to test that patient whether the person have hepatitis B or not. Okay, and even for those patients, we tend to do the profile so that we check their core antibody. If the core antibody is there in the absence of even the surface antigen, they can still reactivate when you suppress their immune system. So this tells you that you don't just go ahead and give immunosuppressive therapy without knowing their hepatitis B status. If you have a patient with HCC, that curative intervention has been planned for. You are going to do a liver transplant or resection of the cancer, then you put them on treatment. If you are going to manage the patient palliatively, it means that reducing the viral load will not improve their symptoms. You understand? If the person have pain because of masses in the liver, if the person have developed ascites, at that time, reduction of the viral load is not going to reduce the ascites. It's not going to reduce the masses in the liver. So putting them on treatment is a cost to the patient without any benefit. So patient with HCC, that palliative management has been planned for. For those patients, you don't put them on treatment. What you do is that you manage the symptoms. Okay. And then patient with HIV co-infection, that's when you put them on treatment. And for those patients, you will give them 2 antiretroviral medication that also have activity against hepatitis B. So most of the time, tenofovir, lamivudine, then you combine with another antiretroviral so that they take it and controls both the viral load of the HIV and that of hepatitis B. The other indications for treatment is HCV, that's hepatitis C co-infection. You know, hepatitis C, now there is a cure for hepatitis C. Okay, you take the drugs for 3 months, and more than 90% of them will be able to eradicate the virus. So we have a cure for hepatitis C now, but for Hep B, as I've said, so far, no cure. And I think the main reason is that hepatitis B is endemic in the lower middle income and then the low income countries. You know, when it comes to health, we pay lip service to it. Okay, so the Europeans and then Americans that were more affected with hepatitis C, they put in a lot of resources and they have been able to come out with a cure for it. So now they don't have much issue when it comes to hepatitis C treatment. If there is co-infection with hepatitis D, that one too you treat. I've talked about immunosuppression. I've talked about HCV. And those with hepatitis B with extra hepatic manifestation, that they come in with glomerulonephritis, dermatological manifestation, polyarthritis nodosa. For these patients, you will treat the hepatitis. So you will put them on treatment. And as I said, those with acute hepatitis, especially in adults, it doesn't become chronic. So based on that, we don't treat. We treat them symptomatically. We don't put them on treatment for hepatitis B. Okay. But those with acute infection that develop fulminant hepatitis. Fulminant hepatitis means that they come in with encephalopathy or coagulopathy. Okay. For this, we need to support them because the virus has overwhelmed their immune system. So they need some external support to make sure that they fight against the virus. So for acute infection, you don't put them on antiviral medication. But once they come in with fulminant hepatitis, then you put them on medication to help the body to fight against the infection. When it comes to healthcare workers, in Europe, what they do is that if you are a healthcare worker and you work in exposure, like you conduct exposure-prone procedure, okay, that one, they make sure that your viral load is less than 200. In US, your viral load should be less than 1,000 IU per mil before they will allow you to work in exposure-prone area. Okay, so those working at theater, the dentist, and other people that use sharp and instrumentation to work. Okay, but in Ghana, we don't have any policy, and I don't think our healthcare system even check whether you have hepatitis B or not to determine which area to work. Okay, once you are afraid that the patient will give you infection, then you also have to have pity on the patient, so that if you get a needle prick and you quickly go and check the patient HIV and hepatitis B, do you also check yours? Okay, before you conduct those procedures on the patient. So I think as a country, we also need to look at this. The other myth or misconception when it comes to hepatitis is that people will tell them not to eat so many things. Okay, but you see, when it comes to viral hepatitis, what you have to recommend for your patient is well-balanced diet. Don't tell them don't eat oil, don't eat meat, don't eat beans, don't eat this. They shouldn't eat. What should they eat? Okay, most of the time you tell them what they shouldn't eat, you don't tell them what they eat. Okay, so hepatitis B, no food is contraindicated. You need to advise them to eat well-balanced diet. And when you put them on treatment, we monitor their viral load, liver function test, we do scan alpha fetoprotein, BUE, and creatinine to see how they are doing. When it comes to prevention, the main thing is immunization. Okay. And there are people that require the immunization more than others. So those who are going to donate blood, we need to test them, or any organ donors, we have to test them, hemodialysis, pregnant women, infant of hepatitis B surface antigen mothers, household and sexual contact with patients with hepatitis B. And as I said, patients that are going to receive immunosuppressive therapy. For these patients, we need to test them, and if they are negative, we give them vaccination. And as I said, it's not everybody that will develop antibodies, even when you get the 3 doses. Okay. So for those who are more likely to get the infection, or patients that are at risk of getting hepatitis B infection, like healthcare workers, after the 3 doses, check your status and see whether you have produced adequate antibodies. Other than that, if you get a needle prick injury, that's where you are going to decide whether you have adequate antibodies to fight against the hepatitis exposure or not. And once you check your antibodies and the titer is more than or equal to 10 IU per ml, then it means that you have adequate antibodies, or you have produced adequate antibodies to fight against any form of infection. When it comes to care of pregnant women, I think we know what we do in this country. All of them are tested for hepatitis B. Okay, when they attend antenatal, most of the time their first prenatal visit, all these labs are done for them. And for us to prevent perinatal transmission, maternal screening is key. Okay, and then antiviral treatment when the viral load is high is also very key. And then infant post-exposure prophylaxis. So what we need to do is that after the mothers have been tested positive for the surface antigen, they have to go ahead and do the other investigations. So the profile is important, the viral load is important, the liver function test is important, abdominal ultrasound scan is important to determine whether they qualify for treatment. If they qualify for treatment, then you put them on treatment. If they do not qualify for treatment and the viral load is more than 200,000 IU per ml, then at the 3rd trimester, we have to put them on tenofovir so that we reduce the viral load at the time of transmission. And if the mother is positive, then it means that at delivery, the baby should receive both the vaccine and then immunoglobulin, okay, to ensure that the baby, because you see, pregnant women do not transmit the hepatitis B in utero because the virus cannot pass through placenta to the babies. Normally, the infection occurs when the baby has been delivered and the cord is being cut. That's where there is a mixture of the baby and the mother's blood. So that's where the baby tends to get exposed to their mother's blood. So when it happens that way, you give them the immunoglobulin. The immunoglobulin ideally is within 12 hours, okay, after delivery, or up to, let's say, 24 hours after delivery. What the anti-immunoglobulin does is that it's a passive antibody, and it stays in the baby for up to about 4 to 6 weeks. No, 4 to 6 months. So it's able to take care of the virus that the baby have been exposed to. Then you start the vaccine at the same time. So by the time the vaccine will start producing the antibodies, the passive one that we have given is already in the system and is working. Okay. But the immunoglobulin is expensive. So if you are able to give both the immunoglobulin and the vaccine, then the babies, about 90% of them are protected. Okay. But it's not all of them that are able to buy the immunoglobulin. But, I think the vaccine is relatively cheap. It's about 25 or 50 Ghana cedis. If the mother cannot buy the immunoglobulin, then the vaccine alone should be given to the baby. And the vaccine alone is able to protect the babies up to about, I think it's about, the effectiveness is about 75%. The vaccine alone. Okay. So, and especially in this country, that most of our mothers, when you check their viral load, their profile, most of them are E antigen negative. And for the E antigen negative, even some studies say that they may not even require immunoglobulin. But so far, no bold statement has come out yet. So it means that even the vaccine alone, when the mother is E antigen negative, can protect the baby. So give the baby the vaccine. Okay, but if the mother can afford both the vaccine and the immunoglobulin, then you give the baby both the vaccine and then the immunoglobulin. And once the mother is positive after giving the vaccination and then the immunoglobulin, then from 9 months, within 9 months and 18 months time, you need to check the baby and see if the baby have responded to the vaccination and then the immunoglobulin. Okay. But if a pregnant woman is clean and is tested negative, then you have to advise them to get the vaccination, because the vaccination is also effective and safe in pregnant women. Okay, so that they will be protected. Okay, so this is what we can do to ensure that the babies do not get the infection from their mothers. And irrespective of the surface antigen status of the mother, all babies that are delivered are supposed to get the vaccine before they leave hospital. I think the midwives are aware. And I think it's in the Road to Health chart. All babies are supposed to get at birth dose of hepatitis B vaccine. Okay? But you see, Ghana is not implementing that because the government says they don't have money to buy the monovalent. The vaccination that the babies are getting is part of the penta for the hepatitis B, and that one starts 6 weeks after delivery. But I see the 6 weeks after delivery, when they send the babies home, do you know what they do to them before they come for the first hepatitis B vaccination? Okay, that's why WHO recommend that all babies, irrespective of the status of the mother, are supposed to get at birth dose. So in this country, what we are supposed to do is to get the monovalent, the one without the combination of the other vaccination, so that we give to the babies before they leave the hospital. And for me, I always say that if government is not providing the birth dose, why can't we encourage the mothers? How can't we educate them so that they can buy the vaccine and then we give to the babies so that the babies are protected from day zero upwards? Okay, and when you do this, you will be able to prevent the childhood hepatitis B infection. And as I said, about 90% of them, if they get the childhood infection, will develop chronicity. Okay, so this is how we care for pregnant women. Okay, the rest I won't go through. But when it comes to the healthcare worker, what we need to do is, if you are, as I said, if you are working in a clinical area and you have not received the vaccine, then I will be surprised. Okay, I will be very surprised. It means that you yourself, you don't value, you don't value your health. So that means that the patient that comes to you, you will not value their health. Okay. And if you are a health worker and you have received the vaccination, 1 month to 2 months after the last dose, check your status and see if you have received adequate antibodies, if you have produced adequate antibodies. If you did not produce antibodies at all, or you have produced less than 10 IU per ml, then it means that you need to undergo the second 3 series of the vaccination. So you have to receive the full dose of the vaccination again. If you get a needle prick injury, for hepatitis B, a needle prick injury, about 6 to 30% of those who get needle prick will, if the patient have hepatitis B, it's likely that up to about 30% of all health workers that receive needle prick from those patients will also develop the infection. If you don't have adequate antibodies to protect you. Okay. So if you are not immunized and you get a needle prick and the person is positive for the surface antigen, if you are a health worker, what you do is that you get the immunoglobulin. Okay, within 12 to 24 hours. Then you start the vaccination at the same time. Then you complete the vaccination. But if you have adequate antibodies, more than 10, then there is no need for you to worry yourself because you are not likely to get the infection. For HIV, needle prick, I think the rate at which the infection will establish is less than 1% for HIV. But for hepatitis B, it's up to about 30%, especially if the E antigen is positive. That's why we shouldn't be more afraid of HIV. You should also be worried about hepatitis B. Okay. So health workers, let's get the vaccination. Let's make sure that we have adequate titers so that we can protect ourselves. But there are some, irrespective of the doses of the vaccination that they receive, will not produce antibodies. Okay. They will not produce any antibodies. So for those patients, your remedy is anytime you get exposed, then you get yourself immunoglobulin. Okay, to take care of yourself. So I will end here for my presentation, and maybe after questions, the Rare Pharmaceuticals will just take about 10 minutes or so to tell us the product that they have in the market. Thank you very much for your attention.
Thank you very much. Dr. Dua, for such a stimulating lecture on hepatitis, viral hepatitis. It's now time for questions and comments, both for in-person, those who are watching this lecture in person, and then online, virtual. Yes, Dr. Edwin. We'll take a few questions.
Thank you very much. Thank you very much, Dr. Online. Sorry. Thank you very much, Dr. Dia, for that brilliant presentation. I'm just wondering, when a child gets the pentavalent, are the antibodies for life or not? I'm asking because I know two teenagers who both had the pentavalent in childhood per the Ghana protocol, and at 18 years, their titers were checked and they were zero, so they had to be vaccinated. Are they in the outside group, or that's the normal thing for the babies who are vaccinated? Thank you.
Good morning. Dr. Dua, please, you mentioned that if a person receives the 3 doses of the vaccination and you recheck in your titers, the antibody titers are less than 10, you would need to be revaccinated again. The revaccination, is that bo- the booster, or there's something else that they refer to as the booster?
Thank you, Dr. Edwin, for the question. You see, now hepatitis B is like yellow fever in terms of the vaccination. So you receive it once and it protects you for life. But the question that you pose, the difficulty is whether the two people in question, when they receive the penta, they produce antibodies at that time, and possibly the antibody level have gone down to an undetectable level. If you get the vaccination and you produce adequate antibodies, as time goes on, the levels will go down to a point that will become undetectable. But I see the body tends to have memory cells. So though there is no antibodies in that person at that time, but when the person gets exposed to the virus, the memory cells come back to life and they produce antibodies against the virus. So now we say that if you get hepatitis B vaccination, it's for life. There is no need to get a booster. If only the 3 doses that you received the first time, you responded to it. Okay. And then, so if you don't respond to the first 3 doses, then it means that it's not a booster anymore. You are going to start the vaccination all over. So you will receive another 3 doses. And most of the people that receive the second one tends to respond. And even there are some people we have to give them double doses, especially if you are obese or overweight. Okay, sometimes you have to give you the double doses of the vaccination for you to be able to produce adequate antibodies.
Thanks for the presentation. Please, you said when you take the vaccine, 2 years or 2 years after the vaccine, you have to go and check for your antibodies that you have received. What if you have passed 2 years and still you want to know? What does it mean? It's relevant to do it or it's not? And secondly, since you are talking about hepatitis B, we have a lot of staffs, new staffs in. What's the plan for us, for UGMC, for the vaccine? Thank you.
Okay, I don't know whether if I said 1 to 2 months or I said 1 to 2 years. So when you receive the third dose, the last dose that you receive 6 months after the first dose, 1 to 2 months after the last dose, then you check your status. Okay, but if you are past that period, especially if you are a health worker, you can check it at any time. And when you check it and the titer is less than 10, get a booster if you are a health worker. But if the titer is more than 10, it means that you are okay. Yeah. As for the staff, I think I'm not in a capacity to answer that question. But as I said, if you are a health care worker, you have worked in a clinical area and you are still working and you haven't get yourself vaccinated, I will be surprised. But since the hospital is supposed to protect their staff, I think I'm sure the public health and then the safety people are working on it. So probably the hospital will take an action concerning your question. Thank you.
Dr. Dua, I have a question for you. What advice would you give to a healthcare worker who several decades ago had incomplete vaccination in terms of 1 or 2 doses rather than the 3?
Okay. So if you receive 1 and you don't continue, then it means that you have to start all over again. But if you're able to get 2 doses and you didn't get the 3rd one, then we say that at any point in time that you realize that you didn't get the 3rd dose, just go for the 3rd dose. Yes. No, irrespective of the years, you can just go for the 3rd dose. But if it is 1, then you have to start all over. If you get 2, and maybe even after 10 years, 20 years, you realize that you didn't get the 3rd one, just go for the 3rd one. Yeah.
The first one states, good presentation, Dr. Dia. What's your comment on boosters? The second one states, I'm not sure if I heard correctly. Is treatment needed if only one of the conditions have not been met or all must be met? Then the third one says, please, is there a window period for babies who missed the immunoglobulin and vaccine at birth? Or once you miss the 24 hours, it is ineffective? Then the fourth one, please, is the monovalent hepatitis B available? Then the last comment is, hello, is there a link for CPD registration?
Okay. I think probably the monovalent vaccine, is that what we have all been receiving? So that one, monovalent, means that there is no additional vaccination added to the hepatitis B vaccine. So it means that the monovalent is available. And that's what we encourage everybody to get. I think the other questions, if you can repeat that. So
Which one, please?
The first one.
The first one. I'm not sure if I heard correctly. Is treatment needed if only one of the conditions have not been met or all must be met?
So I think I'll talk about 11 indications for treatment. I don't know if the person is talking about those without cirrhosis, that you need the viral load if it is E antigen positive, 20,000 and above, together with increase in ALT. Okay, when you do the liver enzymes, ALT should be 2 times the upper limit of normal for that person to qualify for treatment. So that condition, as I said, is a bit complicated there, and I didn't want to go into full details. But I think for those of us who are listening, once the viral load is 20,000 for the E antigen positive and 2,000 for the E antigen negative, and the ALT is 2 times the upper limit of normal, it's an indication for treatment. Okay. If the ALT is normal, irrespective of how high the viral load is, that one, other characteristics comes into effect. The age of the patient. Does the patient have a family history of HCC or liver cirrhosis? Then that one, we put a lot of things together to decide whether the person is going to require treatment or not. It's a bit complex there, and I didn't want to go into details in that one. Okay, but if any patient have that kind of confusion, you refer to the next level. Okay, please the second.
Then your comment on boosters.
So as I said, now hepatitis B vaccination is for life. So once you have responded to the first 3 vaccines, there is no need for booster.
You just received another one. Please, is there a special protocol for treatment of pregnant women with both a B and C?
So for hepatitis C treatment in pregnant women, that one is, the pregnant women for now cannot receive hepatitis C treatment. Okay, so for hep C treatment, they need to be outside the pregnancy range or after delivery or before pregnancy to care before they get pregnant. But for the hepatitis B, the treatment is the same for either you are pregnant or not pregnant once you qualify. The only other thing is that when the viral load is high, then as I said, you put them on treatment 3rd trimester so that we reduce the viral load.
Thank you very much, Dr. Dia, for such a brilliant lecture. Shall we show our application again? Now we'll invite Real Pharmaceuticals, to brief us on the products that they have. They have sponsored this lecture.
Okay, thank you for this opportunity and good morning once again. My name is Lydia Ekuya Intumi, and I'm here with Khadija Masi from Real Pharmaceuticals Limited. So, as a company, our mission is to provide innovative, quality, and affordable drugs to all facilities worldwide. So, I'll talk about 2 major products to this program and also show our other products. So, Dr. Gia has said it's all on Tenofovir. This is our brand, produced by Lara's Lab. And one unique thing about this brand, there are a lot of brands in Ghana, but one unique thing is that the same brand produced here, it's registered in the US and also other markets. So Tenofovir has been recommended by WHO as one of the first line treatment for hepatitis B because it has a high potency against hepatitis B virus and also it has a high resistance barrier. And finally, it is very affordable. So in adults and children above 12 years will take 1 tablet daily. So it's Tenofovir has a high patient compliance and also like I said, it has a high barrier to resistance. So it is recommended for everybody. And also we have a treatment for hepatitis C. We have Nuclopuvir Velpa, which consists of Sopospuvir 400 milligram and Velpatasvir 100 milligram, which is used in the treatment of hepatitis C infection from genotype 1 to genotype 6. So patients without cirrhosis and compensated cirrhosis
will take it once a day for 12 weeks. And those with decompensated cirrhosis will take it together with Ribavirin for 12 weeks. And we also have halogen, which is povidone iodine antiseptic. And what it does is to deactivate viruses in the nasal and the buccal cavity. So that is it, the oral rings. We also have the nasal rings. So before the vaccine came in, Dr. Insia Asare recommended it for use as a protective mechanism against the COVID-19. And a comparative study has also been done comparing halogen to hydrogen peroxide, and it's able to inactivate the virus within 15 seconds, giving it 99.99% compared to that of the hydrogen peroxide, which inactivates the virus for between 1.5 to 3%. So it is very effective. And also the oral can be used for dental purposes as well. We also have instrument decontaminant and Ultra P powder. We are recommending the use of Ultra P powder to all facilities because it doesn't contain chlorine. It's made from non-ionic surfactants and phosphate. You know, chlorine causes rusting of the instrument, but with our brand, it doesn't contain chlorine. So your instruments are sharp as possible and it's safe for use. So that is it. So there's a scoop in it. You just take one scoop into 2 liters of water and it can be kept for 16 hours. So we also have the wipes. Our wipes do not contain alcohol. So studies have also shown with other wipes that this is able to clean stains faster than that of other wipes. So it's recommended for use in all facilities, surfaces, instruments, and everything. So we also have the last product, which is Reproduce. And this one acts as a sterilization agent. And one thing about this is that it's able to, you can keep it when the solution is prepared, you can keep it for 7 days before you change it. That is all. Thank you.
We should keep our social distancing and so on, the safety protocols, COVID protocols. I have one announcement to make. Our consultant gastroenterologist, Dr. Dia, will be here again on Thursday to deliver another lecture in our series. And it's titled Current Trends in the Management of H. pylori Infections. The time is 4:30 to 7 p.m. So I hope that as many as possible would come and listen to the lecture as well as tune in online, to listen. It is gratifying to note that over 100 people, watched this lecture online. That is very good. Thank you all very much for coming. We wish to thank Dr. Dia and Real Pharmaceuticals again. The current trends, it's mainly online because of the time, 4:30 to 7 p.m. It will be virtual. Some are asking how to get the CPD points. We are working with the Medical and Dental Council to get us the number of points that we need, and we'll communicate with all of you. Yeah, once you register here, and those online too, we have their details, so you will get it. Thank you. Just before you leave, there are other professions. It's not only meant for doctors. There are other professional bodies, nurses, pharmacists, allied health workers, etc., are also part of it. Those online would have to send their details for the CPD points to be awarded them. Thank you.